hello. All right, welcome back, everybody. Well, not everybody, but welcome back, those of you who are here. So the three pillars around which the Reimagining the Rural West initiative is being built are connectivity, opportunity, and community. And community really speaks to those factors that make a place a great place to live and work and play. Those things that are going to attract people, that are going to retain people. And clearly that's things like access to quality education, it's civic engagement, it's leadership, it's the arts, but it is most certainly access to health care. And much has been made in recent years about rural hospital closures, and we've all heard stories about how difficult it is to attract and retain doctors and medical professionals to rural communities. And if you don't have access to health care, it makes it all the more difficult to recruit business, to retain residents. And we know that there are higher rates of things like chronic disease among rural populations compared to their urban brethren. So things like diabetes and heart disease, and much higher risk of injury in rural communities. So InterTelehealth, which provides opportunities for medical professionals to treat rural residents remotely and to provide access to specialty care. Telehealth has exploded in the last 10 years. And this panel is going to examine practical barriers to creating remote access healthcare options and also highlight policy opportunities that can help accelerate telehealth offerings in rural communities. We have a great panel today, and I'll start with Joan Connell, who is, Dr. Joan Connell is a pediatrician in Bismarck, North Dakota, and also works for the North Dakota Department of Health as the state's field medical officer. She runs a children's asthma clinic, which uses telehealth offerings to improve pediatric care in rural areas, and she's also managing a state grant to improve pediatric behavioral telehealth services in the state of North Dakota. Rex Forrest is the Vice President for Health Services at Idaho State University-Kasiska Division of Health Sciences. Rex has received numerous honors and recognition for his teaching, research, clinical practice, and his professional service. He's been instrumental in developing the Telepharmacy program with Bengal Pharmacy at ISU. Christa Stadler is the Senior Director of Telehealth Services for St. Luke's Health System. She's a registered nurse who's passionate about improving patients' access to quality, cost-effective care, regardless of their geographic location. And she currently serves as the Senior Director of Telehealth Services at St. Luke's Health System in Boise. And Jennifer Stoll is the Executive Vice President of Government Relations and Public Affairs for OCHIN. As Vice President, Jennifer leads government relations, public affairs, and media relations efforts for OCHIN, which is a national nonprofit healthcare technology and data analytics organization. Jennifer is a public policy champion and expert and is establishing OCHIN as a national leading voice for the safety net in health IT, telehealth, and data policy. So we're going to go from Jennifer on down the line, and Jennifer, thanks for participating today.
Thank you for having me, Jim, and thank you to the Western Governors. I'm Jennifer Stoll. I work for an organization called OCHIN, for those of you that don't know who we are. Although we're based in Portland, we are a national nonprofit health IT and research collaborative. We help safety net providers get access to best-in-class technologies, broadband services, and telehealth platforms, because many in the safety net do not have the staff or the resources to be able to manage or host their own health record system or implement these things. So we support hundreds of health centers, predominantly in the ambulatory space, across the country. So one of our members, as an example, is Winding Waters Health Center out in Enterprise, Oregon. That is truly frontier country. There's not a lot of IT shops around there to help them. So they're one of our members. We did everything from help them trench their fiber. We pull down all their FCC subsidies to run a secure network broadband. We operate the OCHIN Epic platform for them for their health records system. And we have just gone live with telehealth platform through the virtual care through their health records systems, both using a true virtual care platform through the phone and the EHR, as well as integrating e-consult platforms, which is provider to provider communications prior to a referral being made. So in other words, how are we helping health centers access specialists before patients have to drive hundreds of miles to go see a specialist? Can they be treated in their local health center? And we're very proud of Winding Waters as one of our members. U.S. News and World Report just said Enterprise, Oregon is actually one of the best places in the country to receive health care, and they are critical to that. So big props to one of our key members. One of the challenges that we face when working with health centers in rural communities or even underserved urban communities is access to broadband. That is a big piece. We operate a national consortia where we pull down all FCC subsidies if they qualify. And we do that also for hospital systems too in rural areas. We monitor their networks 24/7. We help them keep it secure, make sure there's no outages, things like that. That's a really important thing that health centers don't have people writing grants to be able to pull down FCC subsidies. So that's a big challenge. Having access to broadband, and I know the governor talked about that this morning. The other thing is there are all sorts of strange and archaic rules around telehealth and specifically health centers. And I know we're going to talk about this in a little bit, but we are working to advocate to knock down some of those walls in DC and then also in states to try to update and allow health centers to innovate. Right now, as I mentioned, there's some old laws that prevent them from being really able to innovate. And a health center thinks about, before adopting any new technology, they're going to think about a couple of things. They're going to think about, will this help my patients? Will I get paid? And does it work? Right? And right now, we're still stuck on, will I get paid? So there's a lot of challenges around that. I see a lot of head nodding. So I'll stop there, Jim. But thank you for having me.
Great. Thanks, Jennifer. Joan.
All right. Well, thank you. My name is Joan Connell, and I think I was invited today to tell you with boots on the ground experience about what it took to start an e-asthma clinic. We recognized that children in North Dakota needed specialized care for asthma. So we developed a multidisciplinary live asthma clinic in Bismarck, North Dakota, which is the capital. And we work with a pediatrician, which is me, and asthma educators, and a pharmacist. And that has been really helpful for many patients in our region. What we discovered, particularly around the time of the oil boom in North Dakota, was that we were having patients drive hundreds and hundreds of miles to access our clinic because there was no closer option for them. And in the midst of winter in North Dakota, that's a problem because a lot of times, even if there's a will, there's not a possible way. So that was the spark that invented the e-asthma clinic. And I love that we're following the co-op group because my favorite job as the field medical officer for North Dakota is to forge partnerships, private and public. So both our live asthma clinic and this e-asthma clinic is a partnership between Special Health Services, which is a North Dakota Department of Health division, Catholic Health Initiatives, St. Alexis Hospital, a private hospital corporation, and UND, University of North Dakota Center for Family Medicine. So that exists in both entities. We also utilized the Center for Rural Health, which is run out of UND, to access grant money to purchase our digital tools that I'll have Eric demonstrate in a video. Greetings, and this is your Daily Bite. My name is Dr. Joan Connell, and I'm your Field Medical Officer at the Department of Health. And I'm here with Tracy Hutzler, our respiratory therapist educator and asthma educator at our hub site of our e-asthma clinic. Also joining us today is Bruce Howe, and he is our respiratory therapist at our spoke site in Dickinson, North Dakota. We're getting ready to start our monthly e-asthma clinic, and I wanted to show you some of the tricks of our trade. So Bruce, can you show everybody how to listen to a heart and look in the back of a mouth when you are 100 miles away from me?
Mm-hmm. Yes, I will. What we use is a video otoscope. To look in, I will look into my mouth.
Perfect, great. You can see his uvula, that is awesome, and the back of his tongue. You have a great looking uvula there, Mr. Howe. So now we are listening to Bruce's breath sounds using a digital stethoscope. This connects directly to the computer, and the message of sound is transmitted to us. So that's a breath sound. I can tell that Bruce either doesn't have asthma, or if he has asthma, it's in good control based on how much air is coming in and how much air is coming out, and the balance of those two. So we will see our patients today, and we hope you have a great rest of your day. Thanks for joining us on the Daily Bite. Thanks. A former North Dakotan. Thanks for that support. So that has been a great opportunity for Western North Dakota to have to drive up to 100 miles instead of up to 300 miles to access care. The other thing I will say that I'm involved with is our state received a pediatric mental health care access grant. And you know, Jim, I loved all of the things that you talked about regarding chronic disease problems in rural states. But remember that depression and suicide, we're the leaders of those in rural states as well. So our need for access to quality health care, and I can't say that enough, because a doc in the box type thing where they, oh, you think you have an ear infection, here's some antibiotics. Without inspection of the ear, that is not what we want for our patients in the long run. That will breed antibiotic resistance and make our population sicker in the end. But access to quality health care, whether it's physical health or mental health, is really important. So we don't have any boots on the ground for that yet, but I do have some ideas that if anybody has questions about, I can discuss. And as part of both of these, one of my big fantasy ideas involves centralized care coordination, because those of you who have tried to organize numerous doctor appointments, if you've ever had a big sickness or a parent or a child with a big sickness, it's important to have somebody helping you coordinate those appointments, the other services you need, the follow-up that's necessary. And especially in rural offices, having a full-time staff dedicated to that is often unaffordable. So I do have some ideas on how we could co-op or centralize that in rural states.
Thanks.
Thank you, Dr. Connell. I just want to give you credit. I think a lot of times people think the technology of telehealth is really difficult, and it's the hardest part. And as you saw there, it's actually the simplest part. Everything else about telehealth is very difficult and complex. And so if you like, a former CEO of mine told me once that you have to have a passion for a complexity and a tolerance for ambiguity to be successful. And that was 15 years ago, and the sticky note's still taped to my monitor at work. So my name's Christa Stadler. I'm a registered nurse. I work for St. Luke's Health System that's located in Boise, Idaho. Prior to that, I spent about 10 years at a large health system based out of Phoenix, Arizona that covered 7 western states, working in telemedicine and telehealth. I moved to Boise 5 years ago with my husband and my 4 kids. Knew nobody, left all of our family. And so a lot of people ask me why. And when the opportunity presented itself, I looked at Idaho and I looked at the population, and my husband and I had a real heart-to-heart. And we recognized that telehealth and telemedicine has the opportunity to impact hundreds of thousands of lives in this state. And that was really important to us, that we and our family commit our lives and our professional careers to helping people receive quality health care in a convenient manner. And so that's really our why. St. Luke's Health System, if you don't know about us, we're located in southwestern Idaho. We operate 8 hospitals, 4 of which are critical access hospitals. We have over 200 clinics. Many of them are in rural areas and are multidisciplinary clinics. We have an oncology institute. We also have a rehab hospital that we operate. We are the only children's hospital in the state of Idaho. And we also have a wholly owned, clinically and financially integrated network known as St. Luke's Health Partners. We are actively transforming our business from fee-for-service to value. For those of you in the room who know about that transition, one of the things that sets St. Luke's apart, and one of the reasons I committed to coming there, was that we have over 1/3 of our revenue at full risk. That is huge. Most healthcare organizations have maybe 1% or 10%. What that means is we're transitioning from every time a patient comes in the door to charging them for everything we do, to taking accountability and having a set payment to keep them healthy. We are actively trying to use telehealth to keep people in their homes and in their communities in a way that's convenient so they can do what they want to do, which is live their lives and be with their families rather than, I don't know about you, but hotels are often more comfortable than hospital rooms. And you don't go there for a vacation. So that's really what we're about. A patient's health and access should not be dependent on where they live. We really believe that anybody who walks into any hospital or any clinic should have access to the same care as though they were walking to a hospital or clinic in a metropolitan area. And that's really what we're doing. One of our other assets I didn't list was I had the opportunity to help design, build, and open Idaho's first virtual hospital a year ago. We have a 35,000 square foot hospital where all virtual care is coordinated and run from. I have the opportunity to support a team of project managers, an IT team, and the programs we operate are tele-ICU, telestroke, multiple ambulatory specialty services similar to Dr. Connell's in our rural communities. We also launched and have one of our most successful programs is remote patient management in the home. We support patients with chronic illness to stay in their home and out of the hospital. And we've had tremendous results with that, decreasing ED admissions by 58%, decreasing hospitalizations by 72%, and when patients are admitted, their length of stay has decreased by 82%. So really, really fantastic opportunities, but there are also repercussions that we have to think about when we put these things in place as to what is that going to do if we start moving care into the home? How do we transition our rural communities into being partners in that so that they remain viable healthcare institutions in the areas that they serve? So thank you very much for the opportunity to be here today.
Thanks. My name is Rex Force. I'm a pharmacist, and I also serve as Vice President for Health Sciences at Idaho State University. Idaho State has the primary health education and training mission for the state of Idaho. And about 5 years ago, we set out on a path really to address many of the things that you've just heard about from my co-panelists here. and that is to create better access for healthcare within the communities. And we really wanted to address, thank you, we really wanted to address the drug delivery side of the healthcare system, because having access to pharmaceuticals and medications is extremely important for folks, as we'll see in a moment. And I just have a couple of slides. The elderly are overrepresented in our rural areas. Those folks also tend to be high utilizers of not only medical services but also pharmacy services, and not being able to obtain your prescriptions when you get your health care is a big problem, and it affects the viability of those clinics, critical access hospitals, and other health entities within those communities. And if you don't support the clinic in town, the town tends to end up not being as livable. I wanted to just give you a few facts and figures, and obviously most of you are very familiar with the issues related to rural areas, with about 20% of the U.S. population living in an area that covers over 70% of the U.S. area. That's our rural population. As I just mentioned, about 13% of the U.S. population is over 65, but if you go to the rural areas, it's greater than 20%. And in fact, many of the communities that we're serving in rural Idaho are even greater than that 20%. And that's for a variety of reasons. Obviously, there's out-migration of younger folks from those communities, but there's also retirees moving into some of these communities because they want to live in some of these areas because of recreational quality of life and other opportunities. And so we're seeing retirees move into places like Chalice, Idaho, for example. Idaho has a population of about 1.7 million. Does anybody have an idea how many prescriptions are filled in the state of Idaho each year? It's about 20 million.
Jeez.
And if you look nationwide, the number of prescriptions filled each year is approaching 5 billion prescriptions filled in the United States. For those over 65, they fill on average about 27 prescriptions per year. But the problem that we're dealing with here is that 500 rural communities in the U.S. Have lost their pharmacy services, their only pharmacy services, over the last 10 years or so. And there have been some states that have really pioneered drug delivery in these communities. And in fact, North Dakota has a very robust telepharmacy program. Montana has some telepharmacy services. Alaska and the native healthcare system and an INS system in Alaska has long been doing telepharmacy. But really it was relatively new, very new, 5 years ago in Idaho. This is one of our facilities. This is in Arco at Lost Rivers Medical Center. This is a critical access hospital in Butte County. This is the only pharmacy within that county, and this is one of our telepharmacies. It looks, when you walk in the door, like a regular pharmacy, medications on the shelves, and there's quite a bit of technology at play, and we can talk more about that technology, but all of the supervision of the drug dispensing that occurs in these sites is done by a pharmacist who's located in Pocatello on campus at Idaho State University. These sites are staffed, at least 95% of the time, are staffed with just technicians. Pharmacists do visit the site to do inventory, to make sure that the controlled substances are being handled properly, to meet all the regulatory needs that are required either by the state or the DEA or the federal laws. But really, when you walk into one of these facilities, the person that you're going to meet is a pharmacy technician who is in constant contact, usually wearing a headset, with the pharmacist who's back in Pocatello at the hub site. Not unlike what you saw Dr. Connell speaking to that person at that remote site. We have video and continuous audio connections to them. Every prescription is checked with a video system. Just to give you a little bit of an idea, our first site was developed in Arco. Our next site was in Chalice. These are 80 and 160 road miles from Pocatello. When you look at the one-way distance to the next nearest pharmacy, Arco is 61 miles, one way. Chalice, 59 miles. Council, which is where our third site was created, was 53 miles. That's over 350 road miles from Pocatello. And our most recent site is in Kendrick. We're actually much closer to Kendrick here than Pocatello. It's over 500 road miles to get from Pocatello to Kendrick. And these are all communities where people had a minimum 50-mile round trip to fill a prescription, and all communities that had partnerships with either a critical access hospital, a rural clinic, a community health center, but those facilities did not have outpatient drug distribution available to them. And in 3 of those communities, there's no other pharmacy in the county. So really significant access issues related to getting the drugs. We've talked already about some of the issues in doing this. So bandwidth is one of those issues. When you have internet at your home, you have download and upload. When you're doing telemedicine, you're doing download and upload, and you need a higher bandwidth in both directions than we frequently have when we think of home internet. So when we're doing video and audio continuously, that download and upload is really an issue, and we've run into some problems with that. We want to find space, and we want to be convenient in these communities, and that's been an issue. It's been an issue on campus. This is one of our pharmacies. This single wide, which is a used classroom, is the pharmacy in Chalice. I put this picture up because it has actually the tires and the wheels and the axles and the hitch assembly for this. We had to take that off to make the DEA happy so that we couldn't just tow the pharmacy down the street. And so, yes, it's in place, and the wheels and the hitch are no longer attached to the single wide. We have issues with staffing in these communities. We have to have trained pharmacy technicians. And when there's one in the community, it makes it very, very difficult if somebody goes out on an illness or maternity leave or otherwise to be able to maintain the services within that community. So having trained technicians is really important, and we've been looking at lots of different mechanisms to make sure we have the right staffing. And then we've already heard about payment models, and payment models are step one, but pharmacy is a volume business. The reason these communities do not have pharmacies any longer is there just isn't the volume to sustain a business. And so taking the pharmacist, at least that expense, out of the equation at the local site and centralizing it makes this a little bit more viable from a financial perspective. It still is very difficult. Everyone knows the cost of pharmaceuticals keeps going up. The payments keep going down in terms of the margin to the pharmacy, and it really still is a volume-related business. These individual sites might fill anywhere from 40 to 110 prescriptions a day. Usually we think of a minimum of 200 prescriptions a day to support a single pharmacist. So we have to have that cooperative model in some ways, that is multiple pharmacies in a way working together with a centralized pharmacist for this to work. The other issue is you have to maintain the inventory, right? If you don't have the medications on hand when those patients come in to fill the prescriptions, they're going to have to end up driving anyway. So you have to maintain that inventory, and there's significant cost related to maintaining an inventory in a small pharmacy like this one in Chalice. So I know we're going to talk a little bit more about some of the issues, the pros and cons and the challenges that we've encountered, but I wanted folks to have a little bit of background and kind of see what this operation looks like. So I'm happy to be here, and thanks, Jim. We'll, I guess, hand it back to you.
Great, thank you. And Jennifer signaled and Rex kind of confirmed that we were going to have a bit of a conversation about regulatory obstacles, so let's have that conversation now. What are some of the regulatory or legal impediments to deployment of telehealth or that have dampened innovation in this sector?
Sure, I can go first. And I want to just go back and define what a safety net provider is, making sure people are all on the same page. A safety net provider could be a rural clinic, it could be a public health department, a corrections department, University Health Center. Those are all part of our membership, so I just wanted to orient everybody. One of the biggest challenges that we face is it's not the technology. It is definitely the policies that get into preventing telehealth from being vastly utilized. The biggest issues right now are around licensing and credentialing of providers, what an originating site is. So if the doctor's at their home doing a telehealth visit with somebody, what is their legal liability around that? So that is all being debated right now in Washington, D.C. We are very supportive of the CONNECT Act, which was reintroduced in the Senate. There will be a House version coming out very soon that goes a little bit beyond that takes away a lot of these archaic originating site issues. There will also be more clarification coming from various HHS agencies around giving health centers and others a little bit more comfort about what that looks like from a liability perspective. The other thing I would want to give a plug out to is a bill that was just introduced called the STAR Act. This actually gives health centers the ability to innovate. That's the biggest challenge when you're seeing a patient every 8 minutes and you barely know if your provider is going to show up because they are just maximized at capacity. Saying, well, expand telehealth and do telehealth. It changes everything that they're doing on a day-to-day. They have to vastly change their practice and how their workflows are engineered and everything like that. It takes time and they need support to innovate. This is vastly innovative for them. And so the STAR Act helps health centers. It was introduced by Representative Harder in the House with Congressman Young and Fortenberry, Alaska and Nebraska, as co-sponsors, and Representative Harder's from California. Bipartisan bill that gives health centers the ability to innovate. It will fund them up to $200,000 a health center to be able to incorporate more telehealth. So being able to fund innovation is so important, allowing them to stop and be able to do that. So, you know, there's some archaic rules in place, but just the lack of tolerance for innovation in our extremely busy health centers, and arguably those that are seeing patients that are both Medicare and Medicaid eligible, the sickest of the sick, could be the ones that we take advantage of telehealth the most.
I'd just like to add a little bit about pharmacy specifically. Pharmacy is less under federal rule and law than it is under state rules and laws. And so each state has different sort of tolerances and allowances for the practice of pharmacy as it relates to telepharmacy. And so one of the significant barriers that we ran into was what our state law was and what it would allow us to do. So we literally had to work with our state board of pharmacy and change the rules to be able to do this work. We operated under a waiver initially and had to document the safety, the risk of drug diversion, and some of these other concerns that people obviously would have when you're not having the pharmacist supervise the dispensing of the medication on site. So I think from a regulatory perspective, it's not so much related to the payment, it's not so much related to the federal rules, but it's related to what does your state law allow for the practice of pharmacy. That really makes the difference. And we were fortunate to have a board of pharmacy that was willing to work with us, that was willing to experiment a little bit, and we collected a lot of data for them and fed that back to the board to allay some of their fears over time, to make sure that this was safe, that it was legal, and that it was an effective means for providing medication services in these rural communities.
If I could just add too, there's nothing that would preclude states from doing updating their Medicaid statutes as well, and encouraging your Medicaid providers from doing more telehealth services. What I was speaking to all is applicable to Medicare. on the federal side, but states are really innovating. And what's exciting is the STAR Act was developed from proposals that were introduced in various states. So Oregon, and it was introduced in Washington and a variety of other states to help health centers innovate as well. So many times too, the feds are looking at what the states are doing in this innovative space.
I might add, from a healthcare provider perspective, you know, the four biggest challenges that I've experienced in my 15 years of telehealth have been licensure, credentialing, reimbursement, and geographic barriers. Those are the big four that hands down happen every time. There's been some great movement at the federal level in the last year to really remove some of the restrictions and the barriers that we were experiencing before. And the federal government is getting very creative in creating what we call CPT codes that don't have telehealth behind them. And so that's been very beneficial to patients. That's helped us do our remote patient management program, which really is a centralized care coordination program, because it's not considered telehealth, it's considered electronic transmission of medical information. So we're seeing movement, but it's really important that our states also really look at what barriers are we putting up individually. I have been fortunate to be asked to co-chair a telehealth task force here in the state of Idaho, and we're currently working on that. We're not going to talk about the barriers anymore. We're going to start talking about the solutions. What do we need to do to move forward? Some of the biggest things that I think would be really beneficial in all of our states is removing any type of geographic restriction. I know we're here today to talk about rural communities, but the question begs to answer, why haven't we seen more telehealth in rural communities if it's so great? As a healthcare system employee, I can tell you, and the leader of telehealth at St. Luke's, one of the biggest problems that we have in rural communities is you need to stand up a program that allows access for everybody, regardless of where they live, in order to make it financially viable. Just like Rex said, you know, one pharmacist can fill 200 prescriptions a day, but in these facilities he's in, it's maybe 140. You're not using that asset to the fullest capacity, and so therefore it's very difficult sometimes to keep these things staffed because people get bored. They want to be delivering their maximum contribution. So I'm really hopeful that both at the federal and state level we can see some of the same restrictions that are out there, because I believe that removing it's only allowed in the rural facilities and allowing metropolitan areas to embrace it, you're going to see a lot more healthcare providers and large organizations or middle-sized organizations like St. Luke's really start to invest in programs that they can take to scale across a large geography.
Please, Doctor.
I just want to make a couple of comments. Jennifer, when you were speaking to the fact or the possibility of increasing the location with which providers can provide telehealth, we have a physician shortage, and I have a lot of female professional colleagues who work full-time or who don't, or who work part-time, or who have stopped working because it's impossible to see a patient every eight minutes and then do your charting when your kids go to bed and then take phone calls all night and get up and do it all over again the next day after day after day. So I think this would open up the door for lots of part-time physicians, and a lot of females in that category and some males, a lot of near retirement physicians who can't take the stress anymore, but maybe they could if they could be wearing their slippers at home while they're doing it, literally. I mean, I think this would dramatically increase the availability of physicians.
And Dr. Connell, what's great is that we don't have to wait for the feds to do anything. I mean, right now things that you can appreciate are not really advancing all that fast. What states can do if they are signed on to interstate compacts. There is one for physicians, there's one for nursing, there's one for physician's assistants, there's one for psychology and mental health providers. It streamlines the licensing and credentialing process. So until we can figure out a way to go above the state lines, at least we can streamline and simplify the process to get credentialing in the states. And so it's something that I would call out as a policy that if the states aren't paying attention to it, or haven't signed on to these interstate compacts, they really should.
I agree, and our interstate compact just passed this year. So
I would say along that Interstate Compact line, I came to Idaho on the Nursing Compact license, which was very simple and easy. I was very excited to see the Federation of State Medical Boards pass the Physician Compact. I think there's opportunities for that to be improved. It helped streamline, but it's not as flexible as I think we had hoped. So it's a great start. I'm glad the states are embracing that. I'm glad that's organized, and I'm excited to see where that goes. But there is a lot of opportunities around licensure, and we also have to be very mindful that we want to protect the citizens that we represent or the patients that we care for. I think you alluded to, Dr. Connell, the concern around having physicians who, live in Florida overprescribing for ear infections. That's really important. There's a balance there to make sure that we, as states, make sure our patients are safe, but also open the doors to allow patients or providers to come in, especially in shortage areas like mental health, neurology. We operate telestroke programs. We're launching a large behavioral health initiative. We don't have enough of those providers in the state of Idaho. We will have to look outside of our state. But when we do that, we have very high quality standards that we meet, and we do 100% chart review and claims review to make sure that we're not seeing those things. So there's a lot of complexity and a lot of thoughtfulness that has to go into these programs to make sure that we're not just creating more problems downstream, like over prescribing and those types of things.
Well, and I will tell you, as a physician, I'm the past president of the North Dakota chapter of the American Academy of Pediatrics and the District 6 president for the North Dakota Medical Association. And in both of those associations, a lot of physicians are putting a lot of thought into taking the rulemaking away from the policymakers who have little or no medical education. And we're trying to be at the forefront saying, this is what our standards need to be for telehealth. But it's very controversial, and these are groups made of physicians who are doing that thing I just told you about and then trying to come together on a weekend and make some policies. So I think, I don't know that we'll be able to stay ahead of the curve. But having providers with a lot of experience and expertise at the forefront and guiding policymakers. And nobody really talked about the reimbursement issue specifically. You alluded to it, Jennifer. But in my state, we had this parity bill that was all set to pass. And so what that means is if you get paid $25 for a live asthma visit, you would get paid $25 for a teleasthma visit. Well, at the last minute, one of the lobbyists from one of our healthcare organizations put a bug into the ear of our legislators. So the bill was modified and subsequently passed, saying that if you reimbursed for a live visit for asthma, you had to reimburse for a telehealth visit for asthma, but you could negotiate your reimbursement rate. And I think that's a big problem. And it's really kind of slowed me down from saying, okay, where's our next site?
Well, and that'll continue to drive inequities between payers, and that's what we're very much concerned about. We're seeing in states where the state has advanced policies to open up for commercial payers for those that want to innovate in that space without adopting or increasing policies around the Medicaid side. And so Oregon is an example of a state where now we have an inequity. We have a lot of innovation within the commercially insured, but arguably where we need the innovation is in the health center and the vulnerable populations, but they've been left behind. And so if we don't have that payment comfort, health centers, they don't have the tolerance to innovate. So exactly what you're saying.
Yeah, I'm going to say something a little controversial for my panelists up here, but parity's been around for a long time. It's been a lot of conversations. 39 states have some sort of legislation on the books to talk about telehealth reimbursement. Many of the states that don't have it probably won't have it. They probably won't. It's just what it is. I don't think Idaho will ever have it. So we have to adjust the way that we approach it and really have some heart-to-heart partnerships and cooperatives with our commercial payers, with Medicaid, with the folks that, live and breathe in the communities that we all live in, and say, hey, how are we going to do this? What makes sense? And really show the value proposition around telehealth. When somebody sees that the cost savings of patients, the financial aspects, the soft side of things, where a patient stays close to home and their family can be with them in the last days of their life, that is a tremendous impact. So demonstrating all of those cases and all those pieces really helps people understand why we need to come together and figure out how to pay for these services. St. Luke's being more in the value-based area, we have a little more flexibility. But what I can tell you is if I put my critical access hat on or my rural clinician hat on, I'm not looking at large value-based contracts. I'm still operating on a fee-for-service model. And in a fee-for-service model, telehealth does not make sense for me. So that's a big concern for our rural communities as we talk about reimagining rural healthcare, reimagining our rural communities. We have to be very mindful of the fact that these individual community assets, which are not supported by large health systems or corporations, are going to really struggle to find the value in this if they don't get paid for it, if we don't make access to the technology at a discounted rate, we don't offer them tools of how to do it. It's really hard work, and there's a lot of gray in there that you have to discover. So I think just figuring out how we support our rural communities in conjunction with our urban centers to really align is going to be really key for some of those reimbursement challenges. And even when you do have reimbursement, the docs still don't believe you, just so you know.
Sometimes I do. Krista, I just wanted to, I actually agree with what you said. And I think earlier what you had discussed about some of the services that you're offering via telehealth that really aren't feasibly offered via live because of the timing and scheduling of that. So those are, we don't know how to bill for those services, and that's not an issue in a value-based system, but it would be in a fee-for-service system. But one of the things I wanted to offer, one of the unique things about our e-asthma clinic, that is very efficient cost-wise. We have our certified asthma educators and resident physicians through UND Center for Family Medicine see all of our patients, and then at the end they precept to the attending physician. So my billable time for 4 patients is 30 to 45 minutes rather than 4 hours. So that practically saves hundreds of dollars.
Well, and that's great because you're actually training our workforce to practice in a different way, right?
Exactly.
That's another thing is that providers were trained to practice with hands-on, the personal touch. And so not all providers are going to embrace telehealth. I'm sitting next to a very, very innovative woman because not everybody sees it that way, and so you have to make sure that you not only take your patients, but your providers on a journey to acceptance of this new modality. And it can be done. It can really be done. We still struggle with the fee-for-service because, again, a third of our revenue is value, not all of our revenue, but we believe strongly that we have to find ways in order to take the, you have this plan or you're on this insurance product out of that provider's head, because that's not what as a doctor, as a nurse, or anybody in the provider world looks at. We look at the patient and say, you need help, and this is what I can provide to you. So we're hoping. It's a utopian idea, but I think we can get there.
One of the things, too, that we didn't talk about in telehealth is different use cases that to solve gaps in care. One of the areas that we are spending a lot of time advocating policies around are innovating within school-based health centers. More and more kiddos are getting care in schools, and that's how we reach these a lot of our patients. And we help support about 200 school-based health centers across the country. States can innovate in this space. They can update policies. They can pilot different programs to test and innovate. Having willing school districts look at changing modalities of care in school-based health centers really will help, especially in addressing the opioid crisis, as we have many kiddos that are on IEPs or programs, they have been displaced or they've just been challenged with the opioid crisis. We have so much trauma in our kiddos today, so how we can reach our kiddos in a different capacity, and they're used to talking to screens. So, there's a lot we can do in that from a policy environment to solve a big gap in rural areas.
Any other policy issues in telehealth that merit the attention or consideration of Western governors that anybody would like to bring up before we open it up? Let's open it up to the...
Boring. We've been pretty fun.
You've been awesome.
It is between us and cocktails.
Contributions from the room? Here we go. Alan?
I like the microphone had to come so far. It built up anticipation for my comment. First of all, I wanted to say thank you so much to the panelists. This is brand new to me. I'm in higher education, not healthcare. I'm a consumer of healthcare. But the issues that you've brought up, many of the issues, especially around regulation and licensure, are common issues with higher education. Everything you've said is fascinating. But on to my question. My question is specifically around some of the workforce issues. Chrissy, you mentioned training workforce differently, and then also in the example of the pharmacies, the telepharmacies. I wonder what discussions or what work has even been considered to take those pharmacy techs in these places and provide a career pathway there for those folks to then train in and maybe build some of this community competence around whatever the technicians. I mean, it could be asthma technicians, it could be pharmacy technicians, it could be folks in the mobile vans. To what extent does that happen along with telehealth delivery?
Yeah, it's a really good question. We have partnered with some of the school districts in these small towns to look at ways to not only get students into, for example, a pharmacy technician program, but also then getting them to the university to then pathway through and potentially even go into pharmacy school. It's a long road between being a high school student and serving as a pharmacy tech to then getting into pharmacy school with 3 or 4 years of prerequisites to be done. But that is something that we've been talking about. Certainly just to maintain a supply of pharmacy technicians is really, really critical because it tends to be a bit of a transient kind of career for people. We also have been working on scholarship programs from Bengal Pharmacy to the high schools for students that will be studying at the university. And so the business side of the operation has been giving scholarships the past few years to high school students to get them interested in particularly the health professions to be able to do that. But beyond that, we really haven't, I think, done as much as we probably could to identify opportunities in partnering with the school districts.
I'd like to just add to that. It's a little bit different take on it, but one of the areas that I had an opportunity to comment not too long ago on was residency programs, and WWAMI in particular, and how those programs could be beneficial to telehealth. I took a little bit of a different perspective. So imagine that you are wanting to relocate your family to a rural community, and you're a physician, and maybe your specialty is psychiatry, and it's a town of 1,200 people, and they have a large psychiatric need. You are the only psychiatrist in town, which means Monday through Friday, 24/7, 365, you are the only psychiatrist in town. That's frightening to healthcare providers, both nurses and physicians or any of us, because when you're, in your grubbies and just going down for a gallon of milk, suddenly you find yourself being bombarded with those questions, and you always are willing to help. You also need to have a disconnect on occasion for your own personal mental health therapy, if you will. So one of the things that I think we negate to identify is that when telehealth is in a rural community, we can attract residents to those communities by saying, you're not alone. We will have backup for you. So if, it's hard to have 4.5 neurologists in one critical access hospital. That's how many FTEs you need to staff a position full-time in a hospital. You're not going to get it, but you might get one, and you can supplement that with telehealth for nights, holidays, and weekends. That becomes a little bit more palatable to start to recruit these professionals into these areas where we have great shortage, where they actually want to live and raise their families. So thinking about that is when we produce residents and having those opportunities and sharing with them, hey, look for places that have telehealth opportunities, not because that's how you might deliver care, but it's an offset to your life and your work-life balance that will be important to you later on.
I will just add to that that my boss at UND Center for Family Medicine really likes me working at the Department of Health because I can forge some of these partnerships. And so I told you guys about e-asthma clinic, but we also are working on this e-consult through the Pediatric Mental Health Care Access Grant, and that's going to be a great thing. But our residency director strongly believes that we have to expose these guys as much as possible to telehealth because it's going to be in their future, and there is a training component to it.
Anything else over here? All right.
So one of the things we're working on is we're investigating the feasibility of grocery locker systems, climate-controlled grocery locker systems in towns that do not have a grocery store or access to food. And I'm just wondering, is it possible, regulation-wise or otherwise, to couple that with the delivery of pharmaceuticals?
So mail order is done already. Mail order doesn't help you when you need your prescription tonight. But there are ways to, and again, each state can be different in terms of the storage requirements as well as the security of those kinds of facilities. But there are, in essence, vending machines that have been developed with the right kind of connectivity back to a pharmacy to be able to store and deliver medication. So what you're talking about is possible. Again, it depends state to state what kinds of rules and regulations are in place with your State Pharmacy Practice Act. But yeah, I mean, that's a doable thing.
That's such a great question. I think earlier you talked about silos. Was that you earlier in the day? Might have been Governor Little who talked about silos and how they're great, but when they're connected, you can do a lot more. I think the success in reimagining our rural communities is partnership, and it's unique partnerships. Here we are all representing healthcare, and we've seen different sectors here today, different silos, right, of work. And we're going to have to get really creative about how we partner. No longer is it a healthcare partner to a healthcare partner. It might be a healthcare partner to a waste management company. There's some creative things happening in one of our rural communities here with waste management companies who know the elderly in their towns, and if their garbage cans aren't out the night before, they actually knock on their door and do a wellness check. Very easy things that we can do through partnership, because in small towns, people know who lives in that house. So, a lot of opportunities through, St. Luke's has community health grants that we offer to do those types of things. The USDA has grants that they offer, distance learning and telemedicine grants, which are fantastic. We started telemedicine at St. Luke's prior to me coming there. We received a CMS Innovation Health Grant, a $13 million grant that really launched the tele-ICU program and laid the foundation for all of the other programs, including the building of the virtual care center, through creative partnerships. So I really appreciate that question, because that's the type of thinking that we're going to have to put into place in order to solve some of our rural community situations.
Yeah, I mean, just to that point, Krista, one of the conversations that I'm being brought into now is in California, because of the blackouts, there is power challenges, right? And tying it back into the beginning of the day when we talked about, what does electricity look like and power with the rolling blackouts, none of this stuff works if the provider on the other end of the line is, not able to plug in. So, thinking about redundancy in the power grid and the partners that we need to bring along, and then the broadband piece, it's all tied in together now.
Over here, Tim.
two comments. A term called intertwingularity. Look it up. It's a term that I learned and I probably butchered the pronunciation, but intertwingularity is that everything is connected. There isn't one big issue. And I think today's whole session was about the intertwinement of recreation, of energy, of telemedicine, of everything else in our rural communities. So intertwingularity is probably one of those new millennial terms that I've learned recently. And the second thing, I just want to put a plug in from USDA Rural Development. We do have a distance learning and telemedicine grant program that we can actually help fund some of the infrastructure costs for some of these initiatives.
Great, thank you. Well, I will tell you that this has been a crazy fast hour, and I think we clearly saved one of the best conversations for last. And I want to thank this panel for its very enthusiastic engagement. Thank you very much. Okay, so we've had a little bit of attendee attrition. The good news in that is there's more beer for the rest of us. But before we get to that, I want to thank all of our panelists, all of our attendees, but also like to thank the WGA staff, all of whom have had some involvement in reimagining the Rural West. But I'm going to recognize Lauren Danino, who is kind of managing this project as its quarterback, to offer some reflections and next steps.